all of you to kindly post your questions in the Q&A box. Thank you. Are you able to? Yes.
Yeah.
Yes, so it has come.
Yeah.
Be made.
Slide. Yeah, like slide. There we go. I see Professor Moretti there. Hello. How are you? He's another guru on NIPPV.
So he was there with us for the IAP Neocon, and then he is a very respected viewer in our groups.
Yeah.
Hello.
Hello.
Hello, Professor Moretti. You want to say a few words before we start?
Yes. Thank you.
Okay, so I'm going to.
It's a pleasure for me to listen to you. Thank you.
Thank you.
Okay, so I'm going to talk about non-invasive ventilation modes in 2022 and beyond. I think I'll show you by the end of my talk, based on randomized controlled trials, that future is bright for NIPPV, or nasal intermittent positive pressure ventilation, or NIMV, nasal intermittent mandatory ventilation. People call using different names. So disclosures are, I have a joint patent on RAM nasal cannula and I receive royalties. I have grant support for clinical trials and the Speakers Bureau member in KAC USA. If I receive any honorarium, I donate all of it to charity to help mothers, newborns, and children globally, either through AAP or other non-profit organizations. Okay, I have a question. I'm just making it simple. Randomized controlled trials have shown that NIPPV is superior to nasal Cpap in preventing extubation failures and need for intubations. Do you think it's true or false? That's easy. So I need to convince only 24% of the people. That's great. Okay, here is, okay. Again, my objectives are understand the practice of non-invasive ventilation as a primary mode or a secondary mode of respiratory support, describe the different modes of NIV, describe the role of using nasal high-frequency jet ventilation as a novel means of NIV support. If you don't have jet, you can use nasal oscillatory ventilation. Use of newer technology, NIV+. This is the best thing I think that happened in terms of NIV. You can actually see the pressures at the tip of the nasal interface. Any interface you're using, either RAM cannula, binasal prongs, this Puritan-Bennett ventilator is a software that's approved by FDA, validated. So you can actually, you set a pressure on the ventilator, right? Like 20/6. That's what I usually start. But I don't know if the baby, what is coming out of the prongs or the cannula prongs. So here, based on the resistance, length of the tubing, you know all Poisson's law, they measure at the tip and tell you how much. So if I set it at 20, there's no leak, I get about 18 to 19 centimeters of PIP. If I set PEEP of 6, I get 5 or 5.5. If there is a leak, big leak, it could be 3 or 4. So it tells you in real time. So you can adjust the pressures or minimize the leak. So it's extremely good. I don't know if you have Medtronic's PB980 ventilator. We changed all our ventilators to PB990 after this got approved by FDA, and now we're using it. I'll show you some at the end. So again, there are a number of modes of non-invasive ventilation. I just give you my answer here. Cpap works, I agree, but failures with Cpap are high, unacceptably high. And I'll show you data from randomized controlled trials. So some of you that have attended my previous talks, you might be familiar with this slide. So when we say NIV, you need to make sure what do they mean by NIV. Is it Cpap? Is it CPAP? Is it NIPPV? So nasal Cpap, you can deliver with bubble Cpap, ventilator Cpap, or infant flow driver Cpap. They're all the same. Randomized controlled trials have shown there's no difference between the different modes. At one time, there was a report from Toronto that showed that during bubble CPAP, because of the bubbling, you get some amplitude, like 2 to 3 centimeters, and that could help ventilating the babies with high CO2. But when you compare that with ventilator CPAP, it's the same. Failure rates are similar. Second mode is Cpap or BiPAP or DuoPAP. So it basically mimics Cpap. And why do I say that? The high pressure that you can deliver with a Cpap machine is about 11 to 12 at the most. Sometimes you may be able to get 15 at very high flow rates in the second meter to set the low pressure or Cpap. So the delta pressure is like 11 over 6 or 12 over 6, so 6 centimeters of delta pressure. If the delta pressure that controls the volume gets into the baby really has high CO2, it's impossible to ventilate the baby. That's where Cpap fails. And because of resistance in the system, you have to use a longer inspiratory time, like 0.8 or 1 second. The third, I'll show you data comparing Cpap versus Cpap or DuoPAP or BiPAP. Third mode is NIPPV. It truly mimics invasive ventilation without an endotracheal tube. You make all the changes you do as if the baby's intubated. So I don't even ask if the baby's intubated or not. Somebody shows me the blood gas, 7.23, PCO2 68. I say, okay, go up on the pressure or go up on the rate. So you do exactly. So when I said 20 over 6 as my starting baseline pressure setting on any baby, and then I go up or down based on the response to the blood gas or transcutaneous monitoring. So I already have delta pressure of 14 centimeters, right? 20 minus 6. So you can ventilate the babies if the baby has high CO2 very easily. And the delta pressure can be 20 to 25. For example, if you have 30 over 5, you get 25 centimeters of delta pressure. It's flow limited. Most ventilators nowadays automatically adjust the flow based on your peak inspiratory pressure. If we have to set a flow rate, generally it's about 10 to 12 liters per minute or 3 times the size of the endotracheal prongs. I generally say 10 to 12 liters per minute. Very relatively short inspiratory time. We typically set the inspiratory time as 0.5 seconds. And of course, all of you are looking for this at high flow nasal cannula. I do not recommend in preterm babies. And I'll show you randomized controlled trials, why I don't do that. Pressure is neither measured nor controlled. We have zero idea how much pressure is being delivered, and we have no control on the pressure. So depending on the flow rate, higher the flow rate, higher the pressure. And depending on the baby's respiratory rate, spontaneous breathing, the FiO2 that you dialed in is not what the baby gets. If the baby's tachypneic, his FiO2 that you dialed in gets diluted, he gets lower FiO2. If the baby's breathing slower, you get the FiO2 that you dialed in. So FiO2 is variable. Pressures are not predictable, and that's why I don't like to use high flow nasal cannula, heated, humidified high flow nasal cannula. The other modes that are relatively used uncommonly, but they are nasal high frequency ventilation. So you could use nasal high frequency oscillatory ventilation. There are a couple of randomized controlled trials, and I'll show you at the end of my talk. And then we started using nasal high frequency jet ventilation. We published our experience last year in Journal of Perinatology. The last mode is NIV NAVA. So if you truly want synchronized non-invasive ventilation, NAVA is one way of doing it. Professor Moretti has his ventilator, Giulia ventilator, that also can provide synchronized ventilation. So one of the biggest problems with NIPPV is you can't synchronize. You could use grease-free capsule, which is not available in the US, but grease-free capsule also, location of the capsule makes a huge difference. If you don't put properly, you can go into what is known as phase lock, and the baby will get non-synchronized breaths. But any day, non-synchronized ventilation is better than intubated babies. So ideally, if you have a system that delivers synchronized NIPPV, you can use that. But if you don't have it, which most of them in the world don't have it, including our center, we use non-synchronized or intermittently synchronized with the ventilator. Sometimes it will synchronize. So let's start with the delivery room, and then we'll go to the NICU. So how do we resuscitate babies? Interfaces used for neonatal resuscitation. This is a systematic review. We've been using bag and mask for many, many years, 50, 60 years, right? We still don't know what's the best one. This was 5 randomized controlled trials, about 1,200 babies, using Leardall, Fisher-Paykel, Resusure, Ohio, Ambu, Mass,
Sorry to
shapes.
interrupt, sir. Can we have your voice a bit louder, sir?
Okay. Let me,
Thank you,
maybe
sir.
I'll put the... Okay, can you hear me better?
Yes, sir. Perfect, sir.
All right. Okay. Thank you. Thanks for. So in this study, they concluded there is little high quality evidence for choosing an interface to provide positive pressure ventilation. Binasal cannula appears to offer some advantages over face mask, but need further testing. This was published by a group from Melbourne in 2020. So these are some of the interfaces we use either in the delivery room or in the NICU, right? Face mask, Argyle prongs, Hudson prongs, Inca prongs, or nasal mask. And we also designed the Neotech Ram nasal cannula. It's basically binasal prongs designed like a nasal cannula. So you can attach to a bag, you can attach to a TPs, you can attach to conventional ventilator, or you can attach to high frequency ventilator. Again, this is the only interface we use in our NICU and in our delivery rooms. So what is Ram nasal cannula? It's basically a simple binasal prong interface with a 15-minute adapter, as I mentioned, during neonatal resuscitation in the delivery room to deliver Cpap, sustained inflation. Sometimes we do sustained inflation, even though the SAIL trial, sustained aeration of infant lung, showed a higher mortality in that SAIL group. They really don't know why the babies died. I think it was too much manipulation during giving sustained inflation. So in babies under 28 weeks, if their heart rate is not coming up on Cpap or NIPPV, we will give sustained inflation at 20 centimeters for 10 seconds. NIPPV, TPs. In the NICU, you can do Cpap, NIPPV, or all NIV NAVA, nasal oscillation, nasal jet, low flow cannula. We typically use low flow cannula. Most people define as less than 2 liters per minute. In pediatric ICU patients, we use in our PQs and other PQs. In some people are using it even outpatient settings when they send babies home with tracheostomy or home ventilator, they use the RAM cannula. So let's go back and look at the problems with bag and mask ventilation. This was a study published by Neil Feiner, who is very well published and very well known for his resuscitation, and in 2009. So look at it, they're supposed to bag 20/5. And you can see that as they are bagging, there's no change in PD gap color until they reach the point B, when airway pressure was increased, altered by the operator. So then color change. The tracing 2, you can see that the pressure is not being reached. It's all over the place, even though he told everybody to bag at 20/5. And likely due to significant gas leaks that happen even in experienced hands. These are all neonatologists who did the study. More recently, a second study published by Schmalzer, again from Canada. He has also done lots of studies on resuscitation. He has a big simulation center. So he looked at what happens. This is in 56 babies using a respiratory function monitor. You can see the pressures here, gas flow here, and tidal volume here. So he showed that airway, using a face mask during resuscitation, resulted in airway obstruction, defined as a 75% decrease in the exhaled tidal volume, happened in 1 out of 4 babies. Leaks happened in 1 out of 2 babies. 51% mask leak and airway obstruction, very common in very low birth weight infants with face mask. And that is why they're trying to resuscitate the baby with a face mask. Sometimes they don't respond because of the leaks and airway obstruction. Because when you put a mask, the tongue falls backward and the tongue will obstruct the hypopharynx. Another interesting paper from Netherlands, where they looked at 429 babies, all of them are less than equal to 32 weeks, effect of face mask on breathing pattern. So when they applied the face mask, this is what happened. what is known as trigeminal cardiac reflux. So you probably read it in medical school, forgot about it, that they brought it back to our attention, that there are there are 3 branches of the trigeminal nerve in the face, innervate in the mouth, nose area. And they showed that if you activate the trigeminal cardiac reflux, you put the mask, 54% of the babies became apnea, developed bradycardia or desaturations. So they concluded that whether avoiding sensitive area around the mouth by using alternative interfaces like nasal prongs would decrease the risk for inducing TCR, or trigeminal cardiac reflux. And that's precisely what we did. And this is, Dr. Satyan, as soon as you see this cartoon, he's very good in drawing. And so he gave me this drawing. So what are the advantages of not using ram cannula or Hudson prongs or Inca prongs in the delivery room? Less dead space, because all the gas that you are delivering goes into the hypopharynx. You're totally avoiding the oropharynx, because in the mask, you're also do Mr. Sopa, you partially open the mouth. Some of the gas that you're pushing in is staying in the oropharynx. That doesn't take part in gas exchange. That's anatomical dead space, right? Less chance for TCR, reflux, and less leaks. You just close the nose, put the cannula, and do like this during resuscitation. These are the 3 reasons why binasal prong or a nasal cannula will be more effective during resuscitation than a mask. So this is our own experience, retrospective study published by one of my fellows, Dr. Pedro Paz at that time, my respiratory therapist, and Dr. Manoj Beniwali, who is a faculty now in our place. So we had 102 consecutively resuscitated babies using ram cannula as the interface. Babies weighed from 270 to 4.6 kilo, and in about one fourth of them were less than 1 kilo, and 1 to 2 kilos. And you can see babies requiring chest compressions in the delivery room was 5%, and intubated in the DR, 8% of the babies required intubation. Pneumothorax accidentally was seen on chest X-ray in 5% of the babies, and insure treatment was surfactant was given. At that time, we were using insure technique in about 28% of the babies. Remember, there's a lot of big babies too, 23 to 41 weeks. We did a second retrospective study looking at babies less than 1,500 grams only. There were 221 babies. This is before we started NIPPV in the DR. This is the Cpap group, 27 weeks. The NIPPV group for resuscitation, 27 weeks. Delivery room intubation was much higher, 85% compared to 31% of the babies required intubation. Emergency intubation was also significantly lower if you start using TPs and your finger to support the baby that requires positive pressure support in the delivery room. IVH, no difference. Invasive ventilation at 24 hours of age, 66% compared to 38%. Duration of invasive ventilation was also much less, 11 days compared to 2 days. Surfactant was used in both groups 90% of the time. Remember, all of these babies were around 27 weeks and 900 grams with a standard deviation of 300 or 290. So it is effective both in small babies and in bigger babies. So we also looked at what happens in bigger babies, over 1,500 grams. Again, very similar to the babies under 2,500 grams. Intubation was, these big babies, 14.7% versus 7%. So 50% reduction in the need for intubation. Invasive ventilation at 24 hours of age, 7.6% versus 17%. Median duration of ventilation was also lower. So you can effectively resuscitate the babies using NIPPV in the delivery room if the baby requires positive pressure support or due to respiratory distress, rather than just applying face mask and CPAP. So, okay, what happens if the babies fail CPAP? This was a study by Peter Dargaville from Australasia, published in Neonatology almost 9 years ago. He looked at about 2,000 babies, 25 to 28 week gestation, nearly 10,000 babies between 29 to 32 weeks in this database. If the babies fail nasal CPAP early on, they have a higher risk for pneumothorax, higher risk of death, higher incidence of BPD, or death or BPD was significantly higher. Any major morbidity, one of these morbidities, also significantly higher if the babies fail nasal CPAP early in the first transitional period, either in the delivery room for first 3 to 5 days. Remember, preterm babies' lungs are much more vulnerable to lung injury during the transition period. If we can avoid intubation in the first 5 days safely, you're ahead of the game. You can reduce lung injury, you can reduce BPD, you can decrease the need for intubation. It's similar, even in bigger babies, the babies fail CPAP, they have a higher risk for pneumothorax and any major morbidity. There's a trend, but not statistically significant. Okay, another small, simple question. Again, individual randomized controlled trials with starting nasal CPAP in the delivery room has shown to reduce BPD. True or false? How many of you think if you start babies on CPAP in the DR, it reduces BPD? There have been 7 or 8 international, multinational randomized controls have been published. Did any of the studies show decrease in BPD? How many of you think it decreases BPD? %26. Oh boy, I have to work harder to show you the data. 74% of you think that these randomized control trials showed that CPAP in the delivery room decreases BPD, right? I thought so too. Look at the data. These are 8 randomized control trials published around the globe. TPAS from Netherlands, Colin Marley, all of you know, an internationally known legend in neonatology, from Australia, New Zealand. ROAS from South America used bubble CPAP. CurePap trial from Italy. Support trial by Neil Feiner and then NICHG group in the United States. Vermont Oxford Network delivery room management trial using bubble CPAP. Gopal from Germany, they used CPAP and then surfactant. Canvas from Turkey. Okay, every single trial. Look at the failure rates. When I say failures, these are babies that were randomized to CPAP or intubation in the delivery room. Look at the baby that were randomized to CPAP. What happened to them within the first 5 days of age? Okay, 33% to 52% of the babies failed that were started on CPAP and got intubated within 5 days. I told you, if you can avoid intubation in the first 5 days, you are ahead of the game, right? And here, the support trial, which had the youngest gestation age babies, 26-week gestation, with the mean birth weight of 835 grams. A third of the babies didn't even make it out of the delivery room, got intubated. 83% of the babies, 8 out of 10 babies got intubated in the first 5 days. Support trial, okay? So failure rates, even in none of the studies I did, thank God. It's all done by my colleagues, experts in the field of neonatology. It doesn't seem to work in their expert hands in randomized controlled trials. 1/3 to half of the babies failed and got intubated. Then let's look at the death or BPD. Okay, all these 8 trials, 7 trials that was in the systematic review and meta-analysis. Not a single study showed a difference in BPD. If we put all studies together, number needed to reduce BPD is 35 babies. Okay. But again, these are different population, different inclusion criteria, different gestation age. So individual studies, none of the studies, all of them touched confidence interval 1 or crossed 1. That's why that 74% of you who said that it decreases BPD, it doesn't in individual studies. Yeah, if you treat 35 babies, different population, different CPAP setup, you reduce number needed is 35. I'm not telling you to intubate the babies in the delivery room. You should avoid intubation in the delivery room, but you can do something better than straight CPAP, especially in micropreemies. Okay, so what can we do to prevent CPAP failures? People have done a number of things. One is to choosing a lower threshold for FiO2 for early rescue surfactant therapy, clearly decreases CPAP failure. Optimizing the CPAP pressure, we used to start at 5. Now the recommendations are 6, according to European consensus guidelines. And others have shown, like Kakelaya Venkat from Dallas, he published a paper on a quality improvement bundle where he called OptiSurf. He optimized the CPAP. They all started at 5. increased to 6, and then went to 7 centimeters. And then for 7 centimeters, then the FiO2 was 0.3 or greater, they gave surfactant, and they were able to reduce the Cpap failures down to 10%. So that is their QI. Choosing less LISA, but I don't have time to talk about these things. So today I'm going to talk about alternative modes of non-invasive support to reduce Cpap failure. Okay, now another simple question. In randomized controlled trials, Cpap or BiPAP is superior to nasal Cpap in preventing extubation failures or need for intubation. How many of you think Cpap or BiPAP is better than just straight Cpap? Don't think about what I said. You just say based on randomized controlled trials. $50-50. Okay.
Wedded house.
Yeah. Let me see. If I can show you the data. Okay. A lot of my friends have shown the evidence. The biggest study, called Mother of All Studies, is done by Harish Kripalani, okay, from Canada. Now he was in Philadelphia. Now he went back to Canada. He became Professor Emeritus. So he published a study in New England Journal. All babies are less than 1 kilo, ELBW babies. Everybody less than 30 week gestation, 1,009 babies. Okay. This was published in New England Journal. Title of the paper said, a trial comparing non-invasive ventilation strategies in preterm infants. And then people read the title, read the conclusion, right? Conclusion said, NIPPV doesn't work. I said, time out. This is not a study of NIPPV. So they had in their original table, this column as NIPPV. I changed it to Cpap. I'll tell you why. NIPPV, what they called as NIPPV, 53% of the centers use the Cpap machine. There is no way you can get NIPPV using Cpap machine. I told you, you're limited by the peak inspiratory pressure, low delta pressure. And if you're using a ventilator, they converted the ventilator to work like a Cpap machine because maximum PIP that one can use if you are participating in this trial is 18 centimeters. Okay, 18/5 or 18/6. Okay. So even if you're in the study, I mean, I was in the steering committee for this study, and we decided not to participate because I started 20 minimum. Here, the maximum PIP a babies can get if you're in the study is 18 centimeters. Rate 10 to 40. Inspiratory time 0.3 to 1 second. There is no data on surfactant. Let's look at the population. Okay, 26 weeks, 800 grams, almost similar to support trial population in terms of gestational age and birth weight. Re-intubated post-randomization. 60% of the babies got intubated in the so-called their NIPPV, but I call it a Cpap. 60% of the babies failed nasal Cpap. This is a multinational randomized controlled trial. These are baby either primary Cpap or Cpap or NIPPV or secondary. Half the babies were intubated, and then at the time of extubation, they randomized to Cpap or what they call it as NIPPV, and I told you it's Cpap. And look at that, 80% of the babies got caffeine. We know caffeine independently has been shown to decrease BPD. Look at the BPD rate, absolutely no difference. 33% versus 31%. Death or BPD as a composite outcome, absolutely no difference. So there is no difference between Cpap and Cpap in terms of preventing extubation failures or need for reintubation or BPD or death or BPD. Let's look at other randomized controlled trials. This is by Victor from UK, 8 NICUs. These are 540 babies, pretty good sized number of babies. Gestation age less than 30 weeks, very similar to Harish Kripalani's study, less than 2 weeks of old. And there were about 334 babies were less than 28-week gestation. 236 out of the 540 were more than 28-week gestation. Okay. So re-intubated within 48 hours, whether they are on BiPAP or Cpap, absolutely no difference. 20% of the babies failed. 1 out of 5 babies got intubated. Re-intubated within 7 days, 34% versus 31%. PPD, no difference. So they used a BiPAP machine with a PAP of 8, PEEP of 4, and ITEM of 1 second. Remember, resistance is higher with Cpap or BiPAP. You have to use a longer inspiratory time. And delta pressure, 8/4 is 4 centimeters. There is no way you can ventilate these babies. So that's where they got intubated. Cpap, they used a Cpap of 6 centimeters. Primary outcome, failure of extubation within 48 hours of randomization. They used infant flow advanced by Carefusion. Okay, this is again from Ontario, Canada. They did a systematic review and meta-analysis of 14 studies, about 1,400 babies. Mortality was reported in 10 studies, no difference between Cpap, bubble Cpap, or infant flow or ventilator Cpap. I told you in the beginning itself, whatever Cpap you are using, stay with it. You're using a bubble Cpap in your NICU, stay with it. Venti, you're using ventilator Cpap, you can stay with it. There's no difference between, don't go and change. If you are delivering only Cpap in your unit. BPD, no difference. Nasal injury actually was more common in the bubble Cpap compared to the other 2 modes, which I was surprised. 2-4 relative risk is 2.24 decreased risk. Air leaks, no difference between the modes. So mortality and BPD not different, but there is a higher risk of nasal injury with the use of bubble Cpap in this systematic review. Then people still believe that BiPAP should work. So another randomized controlled trial from Iran, a small study, less than 1,500 grams. They used BiPAP using the Viasis, Cpap using the Viasis infant flow driver, and using the Gillespie capsule, PIP of 7 to 10, PEEP of 4 to 7, rate of 20. All of them are wrong settings. We're going to do an PPV. Yeah, I start the rate of 40. I start the PEEP of 6. I start the PIP of 20, and then I go up or down. Okay. Look at BPD. 33% versus 67%. Again, no difference. So remember, if you're using Gillespie capsule, baby has to have a spontaneous respiratory effort. Otherwise, it won't trigger. Because it's the movement of the abdomen that creates a pressure change on the capsule that is picked up by the machine to deliver the synchronized breaths. The baby's apneic or shallow respiration is not going to synchronize. So now, let's look at randomized controlled trials comparing nasal Cpap versus NIPPV. And look at the failures from 1999 to 2016. So more studies published after that. So this is 1999, when I was a young faculty. We did the study in our unit. Keith Barrington, he was in San Diego at that time. Neil Feiner, he published a paper next year in 2001. Kalof, when he was in Philadelphia. Kugel from Israel. Professor Moretti from Rome. Kishore from India. Lista from Milan. Menses from South America. And again in 2012, we did another 5-center study. Uncle from Turkey. Every single study, at the time of extubation, if you extubate them to Cpap or NIPPV, the failure rates with NIPPV are significantly lower in every single study, 5 to 25%. Whereas in the Cpap trials, the failure rates from 25 to 52%. Remember that, 7 studies. So clearly, you can easily support the baby with NIPPV and avoid intubation or re-intubation in these babies. From different parts of the world, it has been shown from randomized controlled trials, no observation studies. Okay, all of them are randomized controlled trials. So Ferguson et al. From Melbourne, Peter Davis, whom we all know, has come and spoken many times in Kerala. So they did a systematic review in meta-analysis of Cpap versus synchronized or non-synchronized NIPPV and extubation failures. These are studies using synchronized ventilation. In 1999, we used synchronized. Here in non-synchronized. I am so happy. They didn't know how to call Dr. Kripalani's study. They put it as mixed mode. Okay, whether it's synchronized or non-synchronized, there's a statistically significant decrease in the need for intubation or reintubation. Obviously, with synchronized, the risk ratio is much lower, 0.25, whereas here 0.64. Still, statistically significant decrease in the need for intubation with non-synchronized and synchronized NIPPV. If it's mixed mode, which is Cpap, it's no difference because it touches 1. So they also looked at what are the things we do in the NICU that we can maintain the babies off the ventilator, successful extubation. Cpap versus oxygen. You know, when I came to this country or when I was in India practicing pediatrics, we were using oxygen or head box, right? I'm sure all of you have used it. Risk ratio, if you Cpap, it's better. Number needed to treat is 6 babies. Confidence interval 3 to 9 compared to oxygen, because here there's no pressure delivered and babies will fail. Cpap versus high flow nasal cannula, absolutely no difference. Okay? We'll talk about that a little later. Methyl xanthines, aminophylline or caffeine. Most people use caffeine, pretty effective. Number needed to prevent extubation failure is 4 babies. Doxapran, some places use the respiratory stimulant, but it's pretty, they get hepatic failure or necrosis, hypoglycemia, they're twitchy. We used to use doxapran in the 1980s. We stopped using it. And again, randomized controlled trials showed no difference in failures. NIPP with nasal Cpap, number needed to treat 8 babies for successful extubation. Non-synchronized NIPPV versus BiPAP or Cpap, again, 8 babies. Synchronized, 4 babies. I told you synchronized is better than non-synchronized, but non-synchronized is better than Cpap or BiPAP. So they concluded that preterm infant should be extubated to non-invasive respiratory support. Caffeine should be used routinely. Any mode of NIPPV, it's not my statement, their own statement. Any mode of NIPPV is synchronized and non-synchronized is superior to nasal Cpap in preventing extubation failures. Now let's look at another. This is Lemry from Canada, Lafon from US, Colbos, Peter Davis from Australia, Cochrane review in 2017. So they looked at early NIPPV versus Cpap in preterm with RDS in 10 studies, about 1,000 babies. What did they conclude? This is what their conclusion. Early NIPPV in the first 5 days does appear to be superior to nasal Cpap alone for decreasing respiratory failure and need for intubation and endotracheal tube ventilation among preterm babies with RDS. Okay. Then, recently in 2020, Christoph, many of you know, you might have talked at your place, and Ramaswamy from UK, they did a systematic review on the network meta-analysis, looking at 35 studies, 4,000 babies. This is primary respiratory support. That is, as soon as the baby is born, has respiratory distress, they were randomized to NIPPV or nasal Cpap. Okay, looked at 35 studies. And they concluded that the most effective non-invasive mode of respiratory support in preterm babies with RDS was NIPPV. Need for mechanical ventilation, NIPPV is nasal Cpap, the relative risk 0.6, confidence interval 0.44 to 0.77. So there's a statistically significant decrease in the need for intubation if you use NIPPV. Lessons in the BPD or mortality when compared to nasal Cpap, again, 0.74, confidence less than 1. This is primary respiratory support. Okay, what happens? The baby's got intubated in the delivery room. Now he's intubated in the NICU. You're planning to extubate the baby. So secondary mode of support, post-extubation respiratory support. They had 33 studies, 4,000 babies. Okay? This was published in Pediatric Pulmonology, and they looked at, and this is their conclusion. Results of this network meta-analysis indicate synchronized NIPPV might be the most effective continuous flow Cpap, just like bubble Cpap as a continuous flow Cpap, least effective modality for preventing extubation failure. Here is synchronized. This is BiPAP, no difference. High flow nasal cannula, no difference. Nasal high frequency oscillatory ventilation, yes, it decreases. Non-synchronized, synchronized, all of them, the statistically significant decrease in extubation failures, but synchronized NIPV is much more effective. Variable flow CPAP, again, confident it was touching 1. So variable flow CPAP is like if you're using a ventilator CPAP. So again, Lemry and this group looked at what are the effects of by device and synchronization. So if you use a ventilator-generated NIPPV rather than Cpap, IPAP, or DuaPap, number needed to benefit is 13 babies to prevent extubation failures or need for intubation. Bi-level NIPPV, no difference. Mixed devices, no difference. Non-synchronized NIPPV, again, a statistically significant decrease in the need for intubation. Synchronized, same, 5 study. Mixed one, no difference. So both synchronized and non-synchronized NIPPV superior to BiPAP, CPAP, DuaPap, and nasal CPAP. Here is a neo reviews, Eric Jensen from Philadelphia, and he showed synchronized NIPPV versus nasal CPAP after extubation and BPD. Number needed to benefit is 7 babies. Okay, range 4 to 42 babies. Okay, now I think I've convinced you that NIPP is better. Now, how do we use it? Number 1, if you're worried about using higher pressures, NIPP will fail, like the Paresh Kripalani study. If you start 18/5, 18/6, it's going to fail because that is not what the baby gets. Okay, if you set it at 18, it could be 12 or 13, 14, depending on the leak and the size of the prongs. Smaller the prongs, higher the resistance, lower the pressure transmitted. So in smaller babies, you actually have to use higher pressure to overcome the resistance. Okay, so that's all. So baseline, P, we start at 6. Cpap, peak high pressure, PIP, 20. Rate, you always do rate of 40. Why? So every time, many of these preterm babies have hypopnea or apnea, but shallow respiration. So every time the machine kicks in, baby's workup breathing is less. So respiratory unloading is much more striking to use a higher rate. So lots of times babies are on 14 or 12/6, room air, rate of 40. And they are 28 weeks post-menstrual age. They're not going home. So once the baby get to 32 weeks, then I try to come down on the rate and then switch the babies to CPAP. So even on room air, keeping the babies on CPAP promotes lung growth. That's what bubble CPAP does in Colombia. That's very Rakeshani. To keep the babies on CPAP until 32 or 33 weeks, because that stretch promotes lung growth. Flow rate, as I said, adjusted. In babies with BPD, severe BPD and airway disease, sometimes we have to use pressure as high as 35 or 38 and PEEP 6 to 10 centimeters because airway collapses. They get tracheomalacia. So babies with BPD have airway disease, lung disease, parenchymal disease, and vascular problem, right? So in those babies, you want to maintain the bronchus and trachea letting open. So stent them with high PEEP. So use PEEP of 10, sometimes they use 12. Philadelphia, their BPD unit, they use CPAP of as high as 20 centimeters of PEEP, positive and expiratory pressure. So called chronic phase ventilator management, which is totally different than RDS management. Low rate, long inspiratory time, large tidal volume, like 10 to 12 ml per kilo is high PEEP. Here is one of our first babies, nano preemies, 270 grammer, born at 24 weeks. My fellow goes to resuscitation. He couldn't intubate the baby, so we had just brought in Ram cannula a year ago. He said, okay, I'm going to resuscitate the baby with cannula. So baby was successfully resuscitated. And had umbilical arterial line, venous line. And the same baby at 331 days in my follow-up clinic, 377 days in my follow-up clinic. You know, I was young at that time. Now I lost hair. My hair became gray. This is at 5 years of age. This baby is now 11 years old. Moved to Texas. I don't get to see the baby that often. Okay, now let's look at a study is there any randomized control trials using RAM cannula? People ask all the time. I said, yeah, I didn't do it. Luckily, it was done by a group in Israel. They did a comparison of RAM cannula versus binasal prong or mask for NIPPV in preterm babies 24 to 34 week gestation. In this randomized control trial, they used babies were about 900 grams, 29 week gestation, intubation within 72 hours, no difference between the two. Maximum PIPP, they used 19/6 rate of 30, 18/6 rate of 25, very similar. PPD, no difference. Neck, no difference, 2% versus 5%. Time to full feeds, no difference, 9 days versus 8 days. Time to discharge, 59 days to 64 days. What they found was that moderate to severe nasal injury was significantly less, 5% versus 17%. So they call the RAM cannula as Clint. Clint is cannula with long and narrow tubing. That's the RAM cannula they used. So it's a non-inferiority trial. They showed that it's non-inferior to short binasal prongs in providing NIPPV in preterm babies while causing significantly less nasal trauma. Second randomized control trial published from India. I'm glad a lot of you are doing these randomized control trials. This was in 2021, 28 to 34 weeks, bigger babies. In this randomized control trial, they concluded that for preterm babies on Cpap, RAM cannula with cannulate, compared to Hudson prongs, decreases nasal injury without increasing the need for mechanical ventilation. So 5.4% versus 26.4%, almost 5 times more, similar to the study from Israel. So how did we set it up? So we started 20/6, an inspiratory time of 0.5 seconds, rate of 40. When the FiO2 is less than 0.4, PCO2 is less than 60, pH is over 7.25, we wean the PIP first, and then the PEEP, finally the rate. Of NIPPV, and the peak inspiratory pressure is around 15 to 18, PEEP of 5, rate of 20, we transition the baby to Cpap. And then off Cpap, when the Cpap is less than 5 or equal to 5, to low flow cannula. This usually happens around 32 weeks. So we try each of these modes to do weaning for about 24 hours to make sure baby is doing okay. Baby has more desaturation. When I switch the baby to Cpap, I just go back to NIPPV, go back to the previous setting, rate of 20, 15/6, or whatever the baby was on. It's very easy for me to go back and forth. Minimal duration event, try it for 24 hours. Again, some people say during NIPPV, baby closes the glottis. That's not true. In fact, if the baby has hypercapnia, this study was published in 1993. Okay, Journal of Applied Physiology. Hypercapnia actually activates the glottic dilator muscles and opens the larynx in babies. You don't have to worry about not sending gas with NIPPV. Excuse me. So what about nasal oscillation? So this is the baby, X25 weeker. The dad BPD was sent home from another NICU, even on sildenafil. And unfortunately, he was admitted with burns, about 11% from hot water. And parents didn't know the water was too hot. So this baby has the Mapless dressing. So when the baby came with respiratory failure, put the baby on the oscillator and nitric oxide, 10 parts per million. And the baby did very well. Fed the baby with NG tube, and baby was discharged home. This was in 2010. This is the time my nurse said, baby is shaking too much. Can we do something about it? I said, okay. And we went to nasal high frequency jet ventilation. Unfortunately, I think jet is not available outside the US and Canada, but you can use the Draeger or Stefani or other ventilator that gives you high frequency oscillation more. So we used in 18 babies consecutively managed on nasal jet ventilation. So this is the first reported case of nasal high frequency jet ventilation. There is currently a randomized controlled trial on nasal jet ventilation versus nasal Cpap that's ongoing. They're supposed to enroll 40 babies. So this is the RAM cannula, this is the oxygen tubing adapter. We cut the oxygen tubing, connected it to the jet adapter, and then we delivered jet. So if you're using any mode of nasal ventilation, high frequency or jet or oscillation, remember one thing, you have to use lower frequency and longer inspiratory time. Timing is everything. The longer the time, the more tidal volume gets delivered. Lower the frequency, the more tidal volume gets delivered. So typically, if it's using a sensor medics, recommendation is 8 to 10 hertz. You can go to 1-to-1 IE ratio. And if you're using Bronchotron, I'm not sure if you have that, but Draeger, I'm sure you all have it, or Baby Log, 6 to 10 hertz amplitude, use twice the PIP that you had, peak airway pressure, IE ratio 1-to-1, Leone plus or Stefani, variable IE ratio. So you put the same as above. Jet, as I said, I showed you what we do. Okay, here is the best thing that happened, okay? Knowing what the patient actually sees. This is the first ventilator that has this data. PUEDEN Bennett, 980. So I set on the ventilator, PAP of 20, a PEEP of 8. And then it tells you this is mean airway pressure, this is the rate, 40. And this is peak inspiratory pressure at the interface, IF, is 20. P, I said 8, baby's getting 7.6. This is a 24-weeker, 780 grams in my unit right now. Leak, 0.4 liters per minute. Okay, so you can actually see what the baby gets. So there's no more guesswork on, oh, I don't know how much pressure the baby is seeing. Doesn't mean it gets into the lung, but that depends on if the baby keeps the mouth open or big leak, right? But even with leak, you can see what the baby is actually coming through the nose, into the nose. Here is another baby. I set a PIP of 22 and the PEEP of 6. How much the baby is getting? 15. This is the set pressure, PEEP of 6, and this baby is actually on nasal jet. This baby is on NIPP plus nasal jet ventilation. You can see baby's getting a PAP of 15. So even though I dialed 22, baby's getting only 15. So I have room to go up on it because the leak is 2.2 liters. As a percentage, 88% leak. Even with 88% leak, you are able to deliver a pressure of 15 centimeters. So if I see this, I can go up on the PIP to 24, 26, knowing that the baby is not getting 26. Then I will know exactly what's coming out of the interface. Okay. No more guesswork. So here is, we use the nasal jet. You can see that we set the PIP, jet PAP of 20, jet rate of 5 hertz or 300. Jet valve on time, we increased it to 0.28 at 28 milliseconds. IE ratio is still pretty good, 1-to-6. So set PIP 20/5, because in micro preemies, we start with lower PIP, like 23 weeks, 24, 25 weeks on the jet. If you're using as a first intention, jet PIP was set at 20, PIP and PEEP at the interface, 15/4.9. So I said 5, baby got 4.9. Again, all using the RAM cannula. All these babies were on RAM cannula. So leak, 2.2. So no more guesswork. I think if you have the ability to measure what is coming out at the interface, is excellent. So let's go to some case. Oh, let me speed it up, right? Yeah. So 29 weeks, now 1 week old, intubated, PLBW baby. You're considering extubation. Should we extubate this baby to Cpap or high flow cannula? I don't think I have a question. So here are 3 large studies. You're using anywhere from 3 to 8 liters per minute. Collins from Australia, Manley also from Australia, Brad Yoder from Salt Lake City, Utah, in the US. Absolutely no difference in extubation failures, no difference in BPD. High flow nasal cannula versus Cpap. People said, okay, if they're similar, why can't I use high flow nasal cannula, right? Here is why. Don't. Okay, another scenario. You're considering Cpap as high flow nasal cannula. Should we use Cpap or high flow nasal cannula in these ELBW babies? Here is the data. This is nearly all of them are less than 1 kilo. 2,500 babies from 466 level 2, level 3 NICUs. Okay, high flow nasal cannula use is a retrospective study. Is associated with higher risk of death and BPD and longer length of stay in ELBW babies. That is the reason why I don't like to use it. Every single outcome with high flow nasal cannula is bad. Death or BPD, 50% versus 57%. BPD alone, 42 versus 52%. Sorry. Okay, so all the outcomes were bad. ROP, multiple intubation courses, days on ventilator, 18 days versus 25 days. So here is what about in low birth weight babies? A single center randomized control trial, random high flow nasal cannula using vapotherm versus Cpap or BiPAP, no significant difference in primary outcome. What about in low birth weight babies? This is a 33 weeks baby, 1,700 grams. Let's look at the data. This is a study called Hipster trial from Australia and Norway. Roberts published this paper, multinational, non-inferiority design. Trial was stopped early by Data Safety Monitoring Board because failure rates were much higher with high flow nasal cannula. 25% of the babies failed and got intubated compared to 13% from Cpap. So when used for primary support from the beginning, for preterm babies, low birth weight babies, all of them are more than 28 weeks gestation. I'm talking about bigger babies. Okay, high flow nasal cannula failed, almost double. So here is a study by Murki, you're all familiar, Mumbai and Hyderabad, two-center study. He looked at high flow nasal cannula versus nasal Cpap, exactly like what the previous study showed. This study was also stopped early after planned interim analysis that showed high flow nasal cannula babies failed 26% of the time compared to 8% with nasal Cpap. So in randomized controlled trials, in bigger babies, over 28 weeks, high flow nasal cannula fails. What about even more mature babies in the non-tertiary peripheral hospitals, right? You know, they don't have the technology to deliver even Cpap. Can we just use high flow nasal cannula? Small, level 2, non-tertiary centers. What do you think? Heated high flow nasal cannula can result in less failures. You don't have to transport the baby to a tertiary center. I'm really curious to know what people think. Oh boy, 44% of the people think it's true. Okay, I'll show you. Again, Dr. Manley, who thinks high flow nasal cannula should work, keeps on doing studies, good friend of mine. This is in 9 centers called the Hunter trial, randomized control trial, okay? 31 weeks. Look at the baby. Mean gestation like 37 weeks. Mean birth weight, almost 3 kilos. High flow nasal cannula, 6 to 8 liters per minute versus Cpap, 6 to 8 centimeters, trying to match. Treatment failure, 20% compared to 10% nasal Cpap. So they concluded high flow nasal can result in significantly higher incidence of treatment failure than Cpap when used in non-tertiary special care nurseries as early respiratory support in preterm babies. Now, here is another study looking at high flow nasal cannula versus Cpap and NIPP from Japan. Randomized control trial from 6 NICUs published in 2020. Again, they showed that high flow nasal cannula results in significantly higher treatment failures, 26% versus 15%, or 31% versus 16% within 7 days. So I think it's not patient friendly based on studies. Pressure and oxygen delivery is variable, may result in prolonged exposure to pressure or oxygen, maybe used if you want post-extubation in babies over 1250 grams. Again, data doesn't support it, randomized controlled trial. Safer to use Cpap or NIPPV, where you can control the pressure and oxygen. So that's my last slide. I think I've convinced you, based on randomized controlled trials, NIPP when used as the primary mode or following a period of mechanical ventilation, decrease the need for intubation and less BPD. Limited number of randomized clinical trials have shown decreased death or BPD with NIPP. Number needed to 7. Safe, feasible, effective, easy to implement. Failures are similar with CPAP or BiPAP or CPAP or DuoPAP. All of them are same. Jet ventilation may be used as an alternative. For future, less invasive surfactant administration and then NIPP. Or you could do Lisa or CPAP, but failure rates will be higher here. So thank you so much. I'll be happy to answer any questions. I know I went a little bit over. Yeah, 8 minutes.
Thank you so much, sir, for this wonderful lecture. At the end of it, I think you are able to convince us that NIPP is the best mode among all non-invasive ventilation methods. Sir, there are a number of questions which have come up, and we would like to take it one by one.
Sure.
First, I would like to ask you, how do you define CPAP failure with respect to FiO2 or the CPAP pressures?
Very good question. Most of the studies, the CPAP failure was if the FiO2 was consistently over 60%. Remember, alveolar oxygen, PaO2, P uppercase A, at 60% is about 400, which is what causes lung injury and pulmonary hypertension, so-called pre-capillary pulmonary hypertension. So you want the alveolar PaO2 to be lower. You know, Dr. Satyan came up with the word sagittophobia, fear of 60. You really don't want to be 60% oxygen, giving 60% oxygen or greater to the babies. That was one. Second, indication for intubation or failure CPAP was persistent recurrent apnea, at least 2 episodes requiring bag and mask ventilation over a 12-hour period, or blood gas showed respiratory acidosis, pH less than 7.25, PCO2 65 or greater. So these are the 3 criteria most commonly used in all the studies where they defined CPAP failure.
Thank you, sir. So you said that among all forms of CPAP, whether it is a flow driver, the flow driver, or the bubble CPAP, or the ventilator CPAP, all are equal. So there is a question, which CPAP do you use in your unit, and what is the reason behind it?
Okay, so we use ventilator-derived CPAP because we use a lot of NIPPV. So to do that, I need a ventilator. That is the biggest issue. And I hope by November or December, I have a patent on a low-cost ventilator. Some of you might have seen it, Smith ventilator. Names keep changing. It's made in Goa. Now it's made in Medtronic in the US. So it's about, I'm trying to see if we can get it closer to $2,000 or $4,000 at the most. That ventilator can be used in many places, even in very small hospitals, because it doesn't need much. If you're using bubble CPAP, you can use a RAM ventilator very easily. So you need a ventilator. So because we use a lot of NIPPV, and our primary mode of support is NIPPV, use a ventilator. Therefore, when I want to switch to CPAP, I just switch it to CPAP. So I don't have to change anything. That's why we don't do bubble CPAP.
Sure, sir. This is great news for us to hear that a low-cost ventilator is being developed. When the NNF brought out the guidelines on non-invasive ventilation, the clinical practice guidelines, which used the grade methodology, we sort of gave more importance to CPAP, despite the evidence that NIPP works better, because primarily of the contextual reason, because a ventilator may not be available at all settings, and people should be comfortable using CPAP. That's good to know. Yes, sir.
This is portable, carry it on your hand, battery operated, it has Wi-Fi, it will tell you on your phone what the pressures are. These are all neonatals from India wanted us to add. That's what the touch screen they want. So it became a little bit more expensive.
Sure, sir. Thank you. Sir, there's another question. Non-synchronized NIPPV versus synchronized NIPPV. When we do the settings, is there any difference between these two?
Really not. I mean, studies have shown that, like NIV NAVA, for example, you can use lower pressures, peak inspiratory pressures, when you are using synchronized NIPPV. That's the only difference, a few centimeters. Instead of 20, we may be able to ventilate babies 14 or 15 centimeters of PIP.
So do you use synchronized or non-synchronized modes?
Now, we use the, PUEDEN Bennett, and it does synchronize when you have the trigger sensitivity set at 0.2 liters. It's flow synchronization, but it's not consistent. Some breaths are synchronized, some are not synchronized.
So when we use the cannulas for delivering NIPPV, we often get leaks. So when leaks are there, we are not able to use the flow sensors, or synchronizing becomes difficult. So how do we manage leaks?
I think that's why if your ventilator can tell you what the leak is, and if they can compensate for that leak, then, this is the first ventilator that compensates extremely well. That's why we use the PUEDEN Bennett ventilator. We tried Avia before, we tried Drager before. They don't leak compensate. And now I know exactly what I'm delivering with this ventilator. So I can go up on the pressures and compensate for the leak myself by going up on the higher pressure. So therefore, I can safely use higher pressures on the ventilator, knowing that what the baby's getting or what the baby's seeing at the nose.
Sure, sir.
But I don't know if they have Medtronics in India. I'm sure they are.
So there was a mention that the RAM cannula was called the cannula with long, narrow tube. When we say Cpap cannulas, we say that they should snugly fit, whereas with HFNC, leak is the norm. So with RAM cannulas, where do we stand?
You have to have 20 to 30% leak for two reasons. One, when the baby is exhaling, he's going to exhale around the prongs or cannula, right? So you want to reduce expiratory resistance, expiratory work of breathing. Second, I want to avoid any injury to the septum. We have done over 20,000 days of NIPPV. Only 4 babies, fortunately, had transient ischemia or erythema. So you have to avoid nasal injury. That is the key thing. No columnar necrosis has been reported, septal necrosis. So you have to have leak. Therefore, you have to use a little bit higher pressure.
Sure. So when do we call NIPPV failure? Like what settings? We are starting at 20/6.
So it's just in babies less than 28 weeks. If the PIP use is more than 3 centimeters above the gestational age, for example, at 24-weeker, if I'm at 27 centimeters delivered here, then I say, okay, that's too much pressure. I may consider as NIPPV failure or same Cpap failure criteria. But in older babies, we have to use 30 or 35. Then if NIPPV fails, we now have the option of using nasal high-frequency ventilation. So number of babies that fail is becoming considerably less in our unit. And people that use nasal high-frequency too.
Okay, sir. Thank you, sir. We have more questions coming up by Dr. Somshri.
Okay.
So thank you, sir, once again, for your excellent talk. So we have a few more relevant questions. So one question is, as you have mentioned, that ideal PIP should be 20, PWP 6, and that inspiratory time little bit longer, 0.5, with the set respirator at 40. The question is it the same setting you would prefer for irrespective of any gestation and weight, or is there any?
No, any gestation or rate, because the rate, I put it at 40, because I want the baby to grow and not use any energy to breathe. So I support the baby. When the baby takes a little breath, the machine kicks in and supports the baby's breath. So people have done studies putting esophageal catheter, looking at the pleural pressure. So babies that have deep breath, but when the ventilators use the breath, the pleural pressure becomes less negative. Number one. Number two, same pressures, because you remember, in smaller babies, the size of the cannula is small. The resistance is higher. So I'm not delivering 20, I'm delivering about 70% of the PIP I dialed in. Same PIP, if I use the bigger cannula in bigger babies, I'm delivering 90% of the PIP. That's why for ease of practice, we use start at 20 and then go up or down, depending on the gases or transcutaneous.
Okay. So throughout your talk, as you have beautifully mentioned why the NIPPV is better in comparison to Cpap. So in your center, what do you practice basically? Suppose a 700 grammer, 27-week delivered and received TPS resuscitation in the delivery room, and after shifting to NICU, so you start NIPPV directly? Don't
Yeah.
you? Okay.
Number one, I practice what I preach. Okay. There are some people who preach and do different things. Some people have done, they've done their own randomized controlled trials and still come to me and say, hey, you should use that. And I say, you publish the paper and you're telling me to use that mode. So I preach, if I believe in it and if I see the evidence, then I do what I talk to people or I preach. I practice what I preach. So yeah, everybody goes on NIPPV in my unit. Everybody that requires respiratory support goes on NIPPV. In the delivery room, we use NIPPV with the finger, use the T-piece, bring the baby to the NICU, which is very close, and then I put the baby on NIPPV. And if the baby doesn't need it, rapidly wean the baby to CPAP within hours. Even TTN babies, sometimes I put them on NIPPV or nasal CPAP. You remember, we have vent machines on every bed. So the baby doesn't require NIPPV, like a 36-weeker, grunting, required CPAP of 6, FiO2 is 30 or 40%, the D off. I bring the baby to the NICU, put the baby on CPAP of 6 or 7, and see how the baby does. We're still working harder, I add a backup rate.
Okay.
So, but
So,
small babies, the babies you gave example, 23 weekers, they all go on NIPPV.
Okay.
Unless they get intubated in the DR.
Okay. Sir, if we see the RCTs individually, but has been actually included in the systematic review and meta-analysis for the comparison of NIPPV versus CPAP. So there are few contradictory, findings or analysis that maybe the sample size is less, the trials are unblinded, and also the group they use the CPAP is basically low CPAP. So there is practice of high CPAP, like more than 8 centimeters even in few centers. So do you feel the same benefit will be visible in those centers also, in those cases also? So what about the generalizability of these, studies or whatever these RCTs?
So that is the problem, systematic review and meta-analysis, because you're combining different population, different ventilator, different mode of CPAP, and that's the problem. But if you look at individual studies, because they use the same pressures in both groups, right? CPAP, and same in all patients. None of the studies showed a difference. In Australia, at that time, they were using CPAP of 8. Colin Marley, even today, Colin Marley's group, the COIN trial, they said, we will not participate in the trial if you drop the CPAP to less than 8. But that's the practice in Australia. I'm sure some of you trained there. 8 centimeters for everybody. Guess what happened to these babies? Pneumothorax, 9%, 4 times higher in the CPAP group. Why? If the baby got intubated within the first 5 minutes in the delivery room in the COIN trial, they were out of the study, right? So sicker babies are out. Median FiO2 in the baby that were randomized to CPAP, 21%. So these are babies that had no lung disease, and you started CPAP of 8, you get more pneumothorax. So yeah, even with CPAP of 8, failure rates are still high in the COIN trial.
Okay. Sir, one more question. That what about is there any studies which have measured the resistance, the level of resistance, if we use the Rams cannula? Because that is the thing. That is the thing. That is the limitation for this type of device.
Absolutely. There are studies published looking at the 3 different sizes of Ram cannula, published by Robert Chapman and Prabhu Iyer. He's now he was in Cleveland. Now he joined Children's Hospital Los Angeles. He published a paper in a test lung model, and they showed that 70, 80, 90% of the PAP is delivered with small, medium, and newborn size cannula. That have been published in test lung. Now, I exactly have babies on the Ram cannula, and I know what pressure it is. So I can tell what the resistance is.
Okay. So there is one more entity which is called basically low resistance DILC. That is double inspiratory loop cannula. So what is it exactly?
I don't know what that is. I never used it. What is it called? Double?
That is DILC, double inspiratory loop cannula.
I have not used it. It's not available in the US.
Okay.
So.
One more question, sir. So they have asked, so whether there is any, any facility to measure the tidal volume while we
Yeah.
are using NIPPV.
Yeah, I mean, this ventilator does measure the tidal volume delivered. If you, I don't know if you remember, I showed you on the screen. It does measure the tidal volume. Again, inspiratory tidal volume. So that doesn't mean what is actually baby's getting. Ideally, you would like to measure expiratory tidal volume. I think Professor Moretti's system does use expiratory tidal volume to trigger and deliver the breath. So, but most of the ventilator NIPPV settings, they don't measure the tidal volume. We just go by, it does give you the inspiratory tidal volume, but you basically adjust your pressures based on your CO2.
Okay. Sir, many of the centers are using basically the Draeger Babylog 8000 plus for this, this NIPPV. Basically, they're removing the flow sensor and just putting on that SIPPV mode. So is it the right way to use, or there should be the separate software and separate mechanical ventilator?
No, I mean, this is the only PUEDEN ventilator is the only ventilator that actually so far measures that the distal and the interfaces, any interface. But you can use, before that, we used, without knowing what's coming out through the other end, we just assumed that if I said 20 with a small size cannula, based on the in vitro studies, a baby will get 70% of the pressure with a 30% leak. So now I can adjust the leak, or I can go up on the pressure because I know exactly. So when you don't have that, I would still recommend starting at 20 and then going up or down on the PIP based on your CO2 and workup breathing.
Okay. And one more question regarding the term baby, sir, while is having respiratory distress. So what benefit you have shown for the preterms to fail the NIPPV is similarly effective in terms of in comparison to Cpap for these bigger babies also?
I mean, there are no randomized studies in bigger babies. All the randomized controls done when less than 32 weeks or 30 weeks gestation, the 12 studies I showed you. So in bigger babies, the days they stay on a ventilator is pretty low. For example, in our unit, as I said, he used it in NIPPV. Let's say a baby has meconium aspiration syndrome, FiO2 is more than 40. We have them on NIPPV, do LISA, get them, and then wean the babies off the pressure. Even meconium aspiration babies, we don't intubate unless the baby's really sick, bad PPHN. Yeah, but all the TTN babies, we just manage with Cpap or sometimes NIPPV, but no randomized control trials showing that NIPPV is better than. If the mom got mag sulfate or mom got sedation, prolonged C-section, then the baby is not breathing well, then we add a NIPPV rate.
Yeah, so you can continue. Yes.
So there are a couple of questions on how do we handle abdominal distension when babies are on NIPPV?
Yeah, good question. So when I started NIPPV in my unit, my colleague, who's double boarded in neonatology and cardiology, he was actually my attending, that became my colleague, or I became his colleague. He said, he's a brilliant guy. He said, I told you to ventilate the baby's lungs, not ventilate the baby's stomach. So there's so much gas goes into the lung, in the stomach, right? That is the same. Whereas you are on Cpap belly, it's called Cpap belly. The babies get Cpap, if you're on Cpap or NIPPV, the incidence of abdominal distension is same. Time to full feeds in randomized control trials, no difference. Neck, no different. SIP, no different between the two modes. Therefore, we have to put an OG tube. Remember, we are creating this problem because we put an NG tube or OG tube, right, in babies on NIPPV or Cpap. So you open up the lower esophageal sphincter. The lower esophageal sphincter pressure is 9 to 11 centimeters. There is no way you're going to deliver that much pressure to the lower esophageal sphincter. Because we are keeping it open with a feeding tube, we have to feed the baby, the air goes easily at the point of least resistance. So you have to aspirate. So every 3 hours or 2 hours, we have to aspirate. That very soft abdomen, you all have seen that, but it's pretty impressive distension. So we have to aspirate before we feed. That is a problem with any mode of Cpap or NIPPV.
So one more interesting question is, what is the threshold for delivering surfactant when babies are on NIPPV as a primary mode?
We use the FiO2 of 0.3. In babies less than 25 weeks, he's on 23%, 24%. Somebody wants to give it, I say, go ahead and do it. Now, there are, like Cleveland, Rainbow Babies Children's Hospital in Cleveland, it's a level 4 unit. They are giving Lisa, babies from 24 to 34 weeks gestation, on Cpap, they use Cpap. If the FiO2 is even 21, more than 21%, which is surprising to me. They published the paper in last year in their QI bundle. So they wanted to improve the Lisa rate from 0% to 50%. Now they are giving 45% of the babies in their unit are getting Lisa rather than Ensure. And so they're using even 22%. So I think less than 25 weeks, no matter what FiO2, I go ahead and use surfactant. But in babies over 25 weeks, based on the European Consensus guidelines, we use 0.3. That clearly predicts if the FiO2 is more than 30% oxygen. 3 studies have been published, and all of them showed that if you don't give surfactant, or what can predict Cpap failure? FiO2 of 30% or oxygen at 30%. So 30% is still a good number.
Okay. So there is one more question which asks that in some ventilators like the Fabian and Accutronic, when we put on non-invasive modes of ventilation, the ventilator actually changes from flow triggering to pressure triggering. Do you have any comment on this, sir?
Yeah, because they know the leaks are there, so there's no way they can do flow triggering. So they can say, okay, baby can work hard. It doesn't, pressure trigger is harder for the baby to decrease from a Cpap of 6 or PEEP of 6 to 5.5 or 5 centimeters. That's a lot of work. The baby has to be really breathing well. Flow synchronized is much easier to do. But because of the leaks in the system, they say, yeah, I'm telling you flow synchronized, but I cannot compensate for the leak. Therefore, forget about flow synchronization. I'm just cheating you. Therefore, they say, they're honest and say, I'm going to put it to pressure synchronization. But you need to have very little pressure difference, 0.5 centimeter or 1 centimeter at the most. Because when the babies are breathing spontaneously breathing babies, no Cpap, nothing. You know how much negative pressure they generate? 2 centimeters. Just 2 to 3 centimeters. That's negative pressure, pleural pressure. You and me, same thing, 2 centimeters. So you expect the baby on a Cpap of 6, drop it to 4. That is his full spontaneous breathing, and that's impossible to do. That's why pressure triggering, it's very hard for the babies to do. And if you keep it very narrow, you may end up with auto triggering, with water in the circuit and all that.
Thank you, sir. There are a lot of congratulatory messages for you. That it was a very wonderful presentation and everybody enjoyed it, and it is throughout the world. We had around 230 participants logging in today. Any final words from Somshri or Manoj, sir?
So thank you, Dr. Ramanathan, once again. So we're definitely enlightened by today's talk. And also I thank the delegates for their wonderful interaction.
I've been to your place many years ago in Calcutta.
Yes, sure.
Well, it was an amazing session. As usual, Professor Ram's sessions are looked upon like one of the most pricey sessions actually. And he gives very practical messages like the very bold guidance he has given about using the high pressures of 20 and more. Whenever otherwise you don't call it only NIPPV. So such messages you get only from him. And most of the time, we know from time and again that these do stand the test of time. So I have the pleasant duty of thanking all of you, both Dr. Somashri and Dr. Sindhu. Thank you so much for sparing your time and moderating. There are a lot of questions you have summed them up, and then I think you asked most of the questions. Some may still be left out because the number of questions are too many. Thank you so much for sparing your time. I would also like to thank Professor Ram. Again, sir, this is it's a true honor to have you every time, and it's so nice of you not to refuse whenever we invite you. It's a huge honor, I would say.
No, it's an honor for me too, to share whatever knowledge I have, little knowledge I have. So it's always nice.
I know how
when people-
precious your time is and how busy is your schedule is. So it's so very nice of you to do this.
Thank you so much.
And
Stay
to
safe
finally-
and blessed.
Thank you, sir. And finally, I would like to thank all the respected attendees who have been with us for the last 3 years plus now, who are continuously join us in this time zone on Zoom and then later on in the YouTube as well. So thank you all. I would invite all of you for the continuation of this ventilation dialogue in one of the most remarkable trials that keep telling us more and more, gives us more and more insights, the support trial. On 7th September, Wednesday, mind you, it's a Wednesday, our next session alone, because of the request of the faculty, it's going to be on a Wednesday at the same time, 7th September. We will have the lessons from support trial by Professor Valley, Professor Valdemar Carlo, University of Alabama and at Birmingham, Alabama, USA. Until then, thank you everyone. So nice of you. See you next time.